Okay, so we have a few more people and more will be joining us during the event. So we'll be starting. I would like to firstly welcome all of you and thank you all for your presence and interest, obviously, in this talk and in Fagron Genomics in general. So us from Fagron Genomics, we are proud to present one of our partners who's a physician working with the Nutrigen test in Latin America, in Venezuela, and he's been applying the test very carefully and very prominently in his bariatric surgery patients. So Juan Diego is a very known and also very experienced surgeon, and he'll be able to tell us a bit more of his experience with the Nutrigen, and also being able to share with us his knowledge and how the patients have been behaving with respect to their results and how the therapy goes after surgery, and also in the decision of doing or not the bariatric surgery, which is a very important topic whenever it comes to weight loss therapy for patients. So without further ado, I welcome and thank very much Dr. Juan Diego for your presence, and you can start. You can present yourself and go on. I'll be leaving, and I'll be coming later in the end for any questions and answers that might be needed from our side.
Thank you, Gustavo. How are you, everyone? Well, should I start with the presentation?
Yes, please. You can go on with the presentation.
Is everyone visualizing the presentation?
Yes, we can see it. It's fine. They won't. The rest won't be able to. The attendees won't be able to say it, but we can see it.
All right. So good morning, everyone. I am Juan Diego Quintero from Venezuela. I'm a general surgeon. I perform my postgrado in the Zulia University, and then I went for laparoscopy and minimal invasive techniques. Then I went to Mexico to get better in bariatric and metabolic surgery. And then I started working with nutrigenetically tailored diets since 2022. And that changed all our vision. Our goal is to propose a bariatric pre-operative protocol, including genetic tests, recommendations into consideration as a gold standard. Our ongoing research is genetic characteristics associated with the risk of obesity, insulin resistance, and type 2 diabetes mellitus among residents of my city, Valencia, Venezuela, and this is about to be published in a local magazine. So this is the thing, and since 2022, our visions changed because we thought it would be more intelligent or more I don't know, holistic, that all our patients have the information of that we need. So the challenges here are very well known. We have deficiency rates vary widely between patients. We have risk influences by type of surgery and baseline status. We have long-term problems, which like anemia, bone loss, and neurological damage. We have standard supplementation that may not fit all needs. We do know that. And we have genetic lifestyles and surgery outcomes differ, and personalized nutritions improve safety and result. So our status quo is that we have patients that already have nutritional deficiencies, and then when we perform the surgery, those deficiencies are more visible. So we do know that the genetic background, the epigenetic signature, the gene expression, the microbiota is all influenced by a normal or a hypo or a high responder. And we have to have like precision in nutrition in order to have post-operative to have a very good post-operative. So bariatric surgery is on the rise worldwide. Common procedures such as gastric bypass and sleeve gastrectomy is the two surgeries that we do the most. Effective surgery, effective for weight loss and metabolic improvement. Post-surgery, reduced intake and absorption, and high risk of vitamin and mineral deficiencies, and frequent deficit of B12, vitamin D, folate, iron, calcium, and zinc. So we do know that we have deficiencies before the surgery, and we do know that we have more deficiencies after the surgery, more than with the gastric bypass than the sleeve gastrectomy, but with the gastric bypass, we have to be more careful about those deficiencies. If we do not go with the supplement with the patient with these deficiencies, the patient can have anemia, ataxia, hair loss, osteoporosis, poor wound healing, and sometimes, and very low statistically, wernicke encephalopathy. And management of the bariatric patients, healthy nutrition, exercise routine, follow-ups after surgery, a specific treatment with dietary supplements. So we have two concepts that we need to read. That it's nutrigenetics and nutrigenomics. Let me put it. See. Sorry. Can you all see me? Yes. Okay. So we have nutrigenetics that is focused on how our genes affect the way we respond to different nutrients. And in other words, it explains why some people metabolize food differently than others. And nutrigenomics studies how the food we eat influences the expressions of our genes. Nutrigenetics is it's about how genes affect nutrition, while nutrigenomics is about how nutrition affects our genes. In the test, we have 15 macrocategories, which with I very do like all of them, but we put more attention in the in some of them, like glucose metabolism, the intolerances, vitamin and mineral deficiencies. Those are very important categories for us. We in nutrigenetics and nutrigenomics, we give suggestions about personalized formulation in 4 supplementation phases. We have the detoxification 2, transportation or excretion, and supplementation. We provide a food list with 17 food categories divided into carbohydrates rich foods, protein rich foods, and lipid rich foods, and extras. So nutrigenetic testing may identify genetic predisposition that informs tailored post-bariatric care. Middle. So we have these in the micronutrient metabolism. We have the MTHFR that is related with reduced folate activation and homocysteine clearance. As another example, we have the GC that's altered vitamin D transport. We have another example, SOD2 and GPX1 that is associated with oxidative stress and oxidant capacity. We have IL-6 and IL-10 which we all know is associated with inflammation regulation. And we have the TMPRSS6, which is associated with iron homeostasis. In weight regain risk, we have the well-known FTO and MC4R. They are associated with appetite, satiety, and fat storage. And the MC4R is associated with energy balance and adiposity. This is the kind of information we need to have to select a certain procedure from surgical to endoscopic, and we are going to see this in the next slides. In the macronutrient sensitivity, we have the TCF7L2 associated with carbohydrate metabolism and glycemic response. We have the APOA2 associated with fat sensitivity and response to saturated fats. And you have the MCM6 associated with lactose intolerance. And finally, HAL associated with gluten sensitivity markers. So despite diets, medical treatment, and exercise, and lack of information, we do have a percentage of patients that regain weight, mainly after sleeve gastrectomy. And we have not yet identified the obesogenic pattern. The thing is that we operate the patient based on traditional nutrition, and we don't really put the vision in the genetically tailored diet. It's going to give you more information objectively. It's going to be a better, well-grounded decision. We have bad performance of the patient surgery versus reducing potential complications, and intestinal malabsorption versus genetically controlled food absorption. Benefits of a personalized diet. Supplementation is key for the first 2 years of postoperatory, and it's key to protect the endurance of the surgery without side effects. Less dumping syndrome, less SIBO. SIBO is overgrowth syndrome, and plus GVP, so less flatulence, and a very good microbiota. Low levels of bone mass, muscle mass, and mineral after the surgery. Improvement versus remissions of comorbidities. Give me 1 second, please. All right, so let me put it this way. We have 3 paths, 3 solutions. There is no way you could make a decision as well-grounded without genetic information. And after we start, I'm going to talk a little bit about what we do when we have a patient. There's a lot of options we can use, but there's one that is the best. Sometimes the patient wants the surgery, sometimes the patient needs the surgery, sometimes the patient doesn't want they don't want the surgery, but they need it. So when I started working with Fagron Genomics, it changed everything, because the consultation could last about 5 minutes. Do you want the surgery? Do you need the surgery? No, I don't want the surgery. I am very afraid. All right, okay, so bye, you can go. So with genetic tests, we can talk about all your metabolisms, or your deficiencies, your mineral deficiencies, your vitamin deficiencies, your intolerance, and we can get along and we can know each other. I can know the patient better, know how is this patient inside. Is this gonna be a good surgery for me? Is this surgery with this characteristic is gonna be a bad idea for me? It's gonna take a toll on me in the post-operatory. We don't know. So when I started working with this, it gave me a lot of confidence. It gave me a lot of joy because I started again with a lot of motivation, because it's the patient that when they see the report, it's the patient's conclusion that, okay, doctor, it's now I see my glucose metabolism. Now I see that I have a efecto rebote elevado. Now I see that I have insulin resistance and diet, and the risk of diabetes is going to be. I didn't know that the risk was so high. So it put the doctors in the right way. It shows that the doctor is worried about the patient and not about doing surgeries. It shows a little bit of compromise with science and with endocrinology, and it's our vision and our way to work from now to forever with this genetically tailored diet. So case number one is a female of 16 years old. She wants the surgery. She tells the father and mother, 16 years old, adolescent. So she has OMA ER, very high insulin resistance, with hypertrichosis, hirsutism, and depression. She has PCOS, obviously, in their ovaries, and the BMI is 28. Is overweight. Is getting there, but it's not obesity stage 1. And she has a lot of anxiety and only eat pasta, pizza, and sweets. So we started talking about with her, and we told her, we have to slow down. You are very young to perform a surgery. And what happens is that if we operate in this patient, maybe a sleeve gastrectomy, and we don't change the pattern, if we don't change the mind, if we don't give the time to get better, that patient in this female is gonna be from in a years doing another surgery like bypass or something, and she's too young to have a revisional surgery, as we call it. The revisional surgery is when you have your second surgery. So we told her to wait. We needed more information. And here it is. She has a risk of rebound weight gain, genetic risk of overweight, and her basal metabolic rate is not good, and the fat metabolism is not good either. It's better when the unsaturated the PUFAs is better than the MUFAs. But it obviously is in 25.5%. It's not the best. It's not the best. With the carbohydrate metabolism, it's more or less very good, but the capacity to digest starchy food is not good, and she has a little bit of predisposition to the carbohydrates and HDL levels, predisposition to go down. The lipid metabolism is good, but she has the risk of triglycerides, and HDL radio is not good. So she has a little bit of sensitivity for bitter taste and salt sensitivity. The glucose metabolism is no good. It's 37%, with the risk of increased glucose levels in plasma after fasting, and insulin resistance and type 2 diabetes. This patient, she didn't. She usually don't have the breakfast, and it happens a lot. We here in Venezuela, and I don't know in other patients, we have like these sort of gurus that in social media they talk about one specific type of diet, and patient with no information, they follow those diets, and they don't know that they are good for them or not. This is the example that a patient with insulin resistance and risk of diabetes, they do have to have breakfast, because otherwise it would go the level of glucose levels, it will go up, and we don't want that. So one of the features of the test is that your specific diet. If you can go to keto diet, or to Paleolithic diet, or this one with fasting, no, which is very popular. It works for me, but it does not work for her. So also we have lactose intolerance, and gluten intolerance, and this is another thing that I go with my patients. Don't eat the things that have 2 or more deficiencies, with ingredients with glucose and a little bit of lactose, and gluten, like pasta with camarones and milk cream. When you start to add things that more than one, it's gonna take a toll on you. You can have a little bit of sweet, a little bit of lactose, or maybe and a little bit of gluten, but they all together, this is not gonna work for this case. So also we can know the levels of ghrelin expression, and how the receptor is working. If this receptor is not working, so she's gonna have anxiety, and she's gonna be starving and trying to eat every time. And we do know the level of adiponectin, and bisfatin, and also leptin. So if we know the level of expression of these hormones, we can predict if the patient is gonna be a good patient for surgery or not good for surgery. In this case, it could be a very good idea, but the thing is the age, and she's not well prepared mentally to have a healthy surgery. I was suspecting that this patient I didn't want to operate this patient twice, so I gave her a little bit of chance. We can see that the calcium and the magnesium and the iron, they are a little bit low, and I love this because we can start supplementation even before the surgery, and this is awesome. So I talked to her, and we decided to go to GLP-1, GIP agonist, and intragastric balloon with the Fagron food list with the diet. and she loved it. She's a very good patient and has a very good follow-up. And I told her if consider surgery in 3 to 5 years if plan A doesn't work. So it's good for it's been 1 year, and it's very good, and I don't think we have to go to the surgery, and I feel very good for it. So the level, the OMA was very high. The PCOS, the anxiety, the glycemia levels went to 120 to 83. The insulin levels went down. The BMI went from 28 to 24. The quality of life improved. This patient had a lot of things in between her ears, and now she's very she's happy. She's happy she didn't go to surgery, but she have to be careful. And if and we're gonna see in time if the genetic characteristics and the genetics and her habits have a good performance. In this second case, it's a male of 39 years old. He doesn't want the surgery, as the majority of males they don't want to go to an OR. He has bad habits. Glucose levels above 100. DM2 within 5 years. The anxiety, compulsive eating, stress, workaholic, smoker, with diabetes, with HbA1c above 6% and low C-peptide level, BMI of 38 kilograms of metro cuadrado, and stage 2 obesity, hypertension, and he also have symptoms like swelling and abdominal bloating, abdominal gases, and flatulence, tiredness, skin problems, reduced mental concentrations, nervousness, and sleep disorders. So this patient is a very bad patient. He doesn't want to the surgery, but he needs the surgery. When you see him, when you see a patient like this, it's very difficult, because it's about the good habits. You need to go from zero. We can also appreciate that he has very appetite and anxiety risk very high. The genes MC4R and ASH2B1 is medium. The risk of diabetes is high. PAPRG, TCFL, 7L2. There we have the CDK, and we have 4 that are highs, and the rest are medium and low. And then we have the leptin gene is high. The ghrelin expression is high. The vitamin B9 is the risk of vitamin 9 deficiency is high. Of vitamin D is high. Iron levels high. So this patient is crying for the surgery, and our job is to translate these informations into a consideration, and try to the patient to perform the surgery with information, not with what I want. So if we do look at the end, we perform a sleeve gastrectomy, laparoscopy, obviously, and it was great. The thing with the sleeve gastrectomy is that the surgery start working very fast, and the patient, the mindset of the patient changes. The patient does not want to start to eat a lot of and start losing time in boring things. The patient start doing exercise and changing habits, and this patient is a very good patient that I thought it was going to be a bad idea, but he's doing great. The glucose levels dropped significantly. The insulin levels dropped as well. The anxiety levels dropped 50%. The HbA1c dropped from 6 to 4.8, and the BMI went from 38 to 26 in 1 year. Men, they go better with the weight loss more than women, in my experience, or maybe here in Venezuela. Hypertension is they dropped the drop from 150 to 130, and the quality of life of this patient is very, very good. He's my friend, and he have done a great job. He's eating well. He's doing exercises, and he's eating with more intelligence. He knows now what to eat and what to not to eat, and he has better habits. The third case, this is a very good example, because in the final age of her life, from 60 years and above, many people may think that the surgery is not a good idea. I did a sleeve gastrectomy last Friday on a 72-year-old patient that needed the surgery. Needed because she didn't have any sleep. She have a lot of trouble with the glucose metabolism, and with pain and sleep apnea. So she needed the surgery. This patient needed the surgery or wanted the surgery, but he was too late. The thing with this case is that he is too late. Maybe not the age, but the comorbidities. They now are making some weight in the decision. If this patient have less comorbidities, maybe I was going to go for the surgery. But this patient wants the surgery. He has ERC, he has CBC, he has DM2, he has sleep apnea, he has a BMI very high of 42, and has low bone mass, hypovitaminosis, and low minerals. If you look at the test, we have salt sensitivity. The salt sensitivity was there before 10 year old, and that improved that isolated characteristic in time. We was transformed for hypertension. Your body tells you to eat more salty things, and that in 10, 15, 20 years it could elevate your hypertension. So if we perform a Fagron genetic test in the beginning of our ages, is going to be better than performing or doing this diet when you already have the problem. This is a tool that we appreciate a lot, because it gives a lot of information that is gonna prevent. It's gonna, if we do the diet, it's gonna prevent more than 50% in our studies the appearance of this genetically characteristic that is going to show you. It is going to show in any time of your timeline. In this case, the fat metabolism is not very good. The lipid metabolism is not very good as well. The glucose metabolism is slightly bad, 41%. and another lactose intolerance, no efficiency of exercise, uh, minerals dropping, and vitamins as well. You can see this panel with the marker. We can see the gene, we can see the locus, the variant, and the result. And if you observe this panel, you could you can make a lot of conclusions. The conclusions we made in this patient is that if we do the surgery intraoperatively, it was going to be a disaster. He has the indication of a surgery, but the comorbidities is going to make me a lot of headache during the surgery, and we decided to go to another kind of therapy, which was this GLP-1 GIP agonist with endoscopic restrictive procedures such as endoscopic gastroapplication plus Fagron food list, Fagron diet. It was very good. I was very happy with the decision. I love combining therapies, balloon with GIP agonist. In this case, was endoscopic restrictive procedures such as gastroapplication, endoscopic gastroapplication with GLP, GLP for the metabolic response, and endoscopic restrictive procedure for the restrictive procedure. The supplementation and follow-up yearly, Fagron food list, and supplementation and follow-up. So this patient is very good. I was so happy. He went to stage 4 ERC to stage 3. He hasn't had any emergency of CVC related emergencies. Sleep apnea is very good. DM2 is very good also, from 8.5 to 6.3, and the BMI dropped considerably from 32 to 30. And the symptoms of subjectively, the symptoms of osteoarthritis went from 610 to 4, from 6 to 4. So all of our patients, we perform a BAROS, a quality of life test, and they all are in the first case 6 points, which is very good. The second case 7 points, which is very good also, and the third case 5 points, which is normal for the age. So conclusions: personalized diets versus nutrigenetically tailored diets. We have to avoid basic diets or gurus. We have our own nutrition, our own system, and everyone that is going to go to a to a bariatric procedure, or anyone who wants to be aware of how its body works, and it's gonna go for a weight loss alternative. Our recommendation is first get tested. Goodbye to non-specific symptoms. 20% of the population suffers from nutritional deficiencies and food intolerance. So we are operating with this information. We do know that, but we already knew that, but we are not doing doing anything about it. 20%, it's a lot. And when you operate a bypass, and imagine if this patient is in this 20%, it's gonna take a toll on you, because this patient is going to have supplements, but it would be so much better if you can treat these deficiencies before the surgery and after the surgery as well. It's gonna give you more peace. This patient is the symptoms of these patients are gonna drop, and he's gonna feel much better. Also, he has the information in his mind. He knows how his body works, and now he can eat with more intelligence. The degrees of intolerance versus self-imposed restrictions is about that many patients, they stop eating milk, and maybe he or she is a patient of 60, 70 that needs the nutrients that are in the milk, but he puts away the milk because he hurt, or because he's is starting to, like, make sort of like he tries very many diets and many things, and this is like, no, this is the diet that you need. This is the things that you need to eat. This is the things that you have to avoid, and it's more intelligent in that way. Gastric bypass versus hypovitaminosis is a better way to fight with this, is getting tested before the surgery. Excessive or insufficient weight loss and prolongs the benefits of the surgery. Avoids complications like internal hernia and reflux. How to change overweight in adolescents, which was our first case, is how to change behavioral patterns. We need family support. Bariatric surgery during the adolescence is too early for us. You can go with medical treatment with GLP, GIP agonists, gastric balloon, endoscopic bariatric procedures, genetic diet, lots of exercise, and teamwork with endocrinologists and nutritionists. Knowledge is power. Learn to know, nourish, and care yourself. Don't rely on a single weight loss tool. Remember, this is multifactorial. The doctor wants to operate on me versus I choose to have surgery with this doctor. This is very important. Do you truly believe you can achieve success with short-term goals? And are you willing to give up what made you sick? This is the questions that we go with the patient in the consult. With Nutrigen, you can lose 2 to 3 times more weight than a standard low-calorie diet. You have more adherence, you have more compliance, you have more like compromise. You are more compromised when you have more information, you have more motivation. I have patients they are very happy. All of our patients, when they receive the information, the patient report, the doctor report, the food list, they are very pleased because they now they know how their body works. Understand and in a personalized way which foods are favorable and unfavorable according to their metabolism. Understand what supplements, vitamins, and minerals your body needs. A genetic diet and performing moderate to high intensity physical activity will reduce the expression of these genes expression by 45%. So if you eat by a genetically diet, it's gonna be very rare that you could suffer from your risk for those risks. Conclusion: aging depends on a balance between exposure, diet to damage, and the body's resilience to it, anti-aging. And this is an anti-aging tool. A personalized genetic diet can improve the genotype, yes. In a very long time, yes. Genetic tendencies do not determine destiny. They are reversible. Long-term bariatric surgery results and physical exercise can prevent this variation from activating. This is very true. So the surgery plus the diet, it's gonna give you strength. The most effective way to reverse the damage of aging is through nutrition. And what a better way with Fagron Genomics. and prevents post-operative complications such as internal hernia, SIBO, excessive weight loss, and nutritional deficiencies. And it really keeps you in a state of eubiosis that will benefit you throughout your life. So I'm really grateful for this opportunity. I hope you like it, and very thank you.
Well, firstly, thank you very much, Dr. Quintero. It was a great presentation and it was really clear. And I think everyone could enjoy the information you presented to us. So that we can continue, I would like to ask everyone if any of you have any questions. We'd be more than glad to answer. If you want to either point out any questions and I can let you speak, or if you want to write on the chat or the question and answers utility of Teams, please do so. One question from our side, Dr. Quintero. How long have you been using the Nutrigen in your practice? I mean, how many years have you had of experience with the Nutrigen?
Okay, I've been working with genetically tailored diet since 2022. We have 75 patients. We know it's not a lot, but for our situation, maybe it's a little expensive for some people. For other people, don't. But it gave us a lot of happiness to work with with these tests.
Perfect. Oh, thank you, Sasha. Great to hear from you. Dr. Quintero, one question. What would you say was the main difference you noticed kind of in a practice, like in a very practical way? The difference you noticed from before you started using a genetic tailored diet to after? What do you see as a kind of a takeaway message for everyone?
It's amazing. And now I can talk about endocrinology, and now I can talk about genes, now I can talk about receptors, now I can talk about ghrelin, leptin. It gave me a way to be better. I think if you work with genetic, you're working very intelligent. You know, it's not based on opinions. It's based on very well-grounded information. Like I said, sometimes the consultations may be a little bit boring if you don't have this kind of information. But when you have this information, the patient the patient knows that you are really in a compromise with this with him or with her, and that compromise shows that you care. If you care, it's okay. So in Venezuela, we do care about all our patients. He knows that if you are giving this information and you're trying to sell the genetic test, it's gonna give the patient more information. It's gonna be better. So we know that this is new. We know that we are the only one doing this in Venezuela, but we are willing to present this in the National Congress for everyone to see it. I would love for every bariatric surgery work with the genetically tailored diet, because it's gonna give them more information. It's gonna give them less complication, and the relationship with the patient and the doctor is gonna be more. It's gonna be better, and it's awesome. It's gonna work better. The resolution of the comorbidities are gonna be faster.
Perfect. Well, thank you very much for all your insights. It's really clear for us to understand really the difference and really the kind of information you get from using genetics in the bariatric surgery. And I think that the takeaway message you've given us really is interesting and really important to kind of further the message that once you have more information from the patient, you end up being better able to treat them. So thank you again very much for your presence. Thank you very much for sharing with us all your knowledge. I'll get back again to the attendees, to the audience, and check with any one of you if you have any questions that could be remaining before we end. But obviously also we are more than happy to receive any questions later through our channels of communication, and we may discuss them, as well as we will be posting this webinar to our website so you can review it and also share with your peers.
Well, thank you, everyone. Part of my English, it's not my
natural
tongue.
Good.
But I appreciate the effort of everyone, and thank you, Fagron, for the invitation.
Thank you, everyone, and thank you very much again, Dr. Quintero. It was really great to have you with us.
Thank you very much.
Bye, everyone, and thank you. And do contact us if you need anything.
Bye.
Bye-bye.